Visit the YouTube channel and subscribe for more oncology videos.
In our body, there are sites where chromaffin tissue are present. Two most important sites of chromaffin tissues are adrenal glands and autonomic ganglia. Autonomic ganglia can be sympathetic, which is mainly in thoracolumbar region, and parasympathetic, mainly in craniosacral region. Tumors of chromaffin tissue arising from adrenal gland are called pheochromocytoma, and those arising from sympathetic ganglia in thorax and abdomen are called extraadrenal pheochromocytoma, like in retroperitoneum. Those arising from parasympathetic ganglia of cranial and sacral region are called paraganglioma. Adrenal glands have two parts, outer cortex and inner medulla. Chromaffin tissue is present in medulla of adrenal gland, hence it is site of pheochromocytoma. In sympathetic ganglia and adrenal gland, L-dopa is converted into dopamine, which then converts into norepinephrine or noradrenaline. These reactions are common in sympathetic ganglia and adrenal, but in adrenal gland, further reaction occurs by conversion of norepinephrine to epinephrine or adrenaline. Hence the term, epinephrine, above nephrous, above kidney. Adrenaline means from adrenal. Norepinephrine means not above kidney, and noradrenaline means not from adrenal. Consequently, adrenal pheochromocytoma secretes both norepinephrine and epinephrine, while extraadrenal pheochromocytoma produces mainly norepinephrine. Rarely, pheochromocytoma may produce exclusively dopamine. Pheo means brown. Chroma means color. Cytoma signifies bunch of cells. This name is given because when dichromium salts are added to pheochromocytoma, all catecholamines react with chromium to become brown pigment. Norepinephrine and epinephrine become adrenochrome and noradrenochrome. There is a long list of symptoms and signs, but none specifically for pheochromocytoma. Hence this tumor is often missed. Clinical features are either due to catecholamine excess if it is secreting them, or pressure symptoms in non-secreting tumor. Since clinical feature mimics many disease, hence this tumor is also known as great mimic. The secret to successfully diagnosing pheochromocytoma is to first think of it. Norepinephrine in adrenal gland gets converted to epinephrine by help of enzyme PNMT. This enzyme is found in adrenal gland and not in paragangliomas. This enzyme is steroid dependent, hence there is local availability of steroid in adjacent adrenal cortex, leading to enzyme activation. This is why extraadrenal pheos and paragangliomas do not usually secrete epinephrine. Catecholamines are metabolized by enzyme COMT, and metabolites are methoxytyramine, metanephrine and normetanephrine. We can detect blood and urine the elevated levels of catecholamines and level of metabolites. But there is one problem. Secretion of catecholamines from tumor is intermittent, episodic. So normal catecholamine levels may not rule out Pheo. Plus some tumor do not secrete catecholamines. If we look at metabolite secretion, then even if catecholamine secretion is episodic, metabolites are continuously secreted due to continuous metabolism of catecholamines in tumor tissue, whether catecholamines are secreted or not. Hence blood and urine normetanephrine and metanephrine levels are better tests in Pheo. Negative levels of metabolites in blood excludes Pheo, but if positive it must be confirmed by 24-hour urine metabolites test. Once biochemical confirmation is done, then imaging is done to localize Pheo and look for metastasis and extraadrenal paragangliomas, if adrenals are normal. For this, CT is preferred, followed by MRI. More specific investigations to confirm after CT MRI are PET scan and MIBG scan. Pheo secretes catecholamines, which causes vasoconstriction through alpha receptors. Excess narrowing of vessels decreases effective blood volume, despite hypertension. Once Pheo is removed, there is sudden drop in catecholamines, leading to acute vasodilatation. Since blood volume is low, sudden vasodilatation causes life-threatening hypertension. So we have to prime our body for withdrawal of catecholamines by blocking alpha receptors and inducing vasodilation. To prevent hypertension, we increase fluid and electrolytes intake to increase blood volume. So body vessels by time of surgery are already vasodilated with adequate volume. Hence Pheo can then be removed safely and catecholamines withdrawal is well tolerated. Once adequate alpha blockade is achieved, there is increased beta receptor activation on heart, leading to tachycardia. Then beta blockers are added to slow down heart rate. Surgery of Pheo is tricky one. Despite all pre-op blockade, There is always risk of catecholamine surge while handling Pheo, leading to BP increase. Hence surgeon must mobilize Pheo with minimal handling. Surgeon then ligates all vessels of Pheo through which catecholamines may enter in circulation. At last surgeon handles Pheo and removes it. Anesthetist's role is very important in Pheo as there are two main problems in Pheo surgery. Preventing hypertensive crisis. Anesthetists may use strong BP lowering drugs like sodium nitroprusside, nitroglycerines, esmolol. Another problem is to avoid postoperative hypertension due to sudden withdrawal of catecholamines plus intraop use of BP lowering drugs.
Visit the YouTube channel and subscribe for more oncology videos.